making the gastroesophageal angle to eliminate the gastroesophageal reflux. That is the problem later. And that is the thing that we have to say to every pediatric surgeon, that it is very important to redo the gastroesophageal angle. What do you think?
So normally the defect is on the lateral side. Only if it is a very big defect that we will be able to see the gastroesophageal angle, and the left lobe of the liver is coming in between. Though we know we should do that, but usually in our practice, we don't go searching under the liver to look for the gastroesophageal angle. We just try and put the stomach down as much as we can. What do you say, Professor Al?
I mean, I agree with you. I raised my hand to highlight another area with the diaphragmatic hernias. So, with your permission, if I may just maybe divert a little bit from what is being discussed now. So, we being a global organization as WOFAPS, we're very much aware of very different circumstances in different parts of the world, and every country, every region, every hospital, they develop their own way of best managing the conditions within the resources available. But because we're talking about pediatric surgery, and we also want to highlight what is being achieved in pediatric surgery, and perhaps there may be young colleagues who are thinking of a specialty and they're looking at these conversations as a potential aspiration for themselves, whether they will move into pediatric surgery or not. The advancements have been such wonderful in the last 50 years. We are able to see one of them in this condition of diaphragmatic hernia, where fetal surgery has been brought in. It's not available everywhere. It's in fact available in very few centers, of course, but it's just to indicate how much pediatric surgery has developed to a point that they can actually intervene during the fetal life when the diagnosis is made. And we mentioned that the lung capacity and the lung maturity is important in this condition. Help the lungs to grow and function better when the baby is born. But that intervention takes place during fetal life. So as I said, there are very few centers obviously offering this, but it's again a wonderful representation of how much pediatric surgery has advanced in the last 50 years. Thank you.
Thank you. So for the layman, now a balloon can be put into the trachea while the baby is still in the mother's womb with a small endoscope around 2.5 millimeters, that much small. So they can go inside, put in a balloon, and that balloon allow the fluid. It allows the fluid to remain in the lung. It doesn't go out. So with that fluid, the lung expands and pushes the contents which are in the chest down. So the lung is able to grow and the contents are reduced. Just before delivery, the balloon is either punctured or allowed to be taken out when the baby is born, and he just swallows it out. So Professor Ochwa, what do you think? Is this the way to go? Will this be the future, that all babies will be diagnosed during the antenatal period with an ultrasound, and many of them will be subjected to this fetal surgery? Or is it still time to wait, because we know that there may be some anesthetic effects on the baby which is within the mother's womb during anesthesia to the mother?
Normally, until now, or in my time, almost all the babies were diagnosed after the delivery, but not before. I don't have any experience about doing minimal invasive surgery. I have experience doing the balloon afterward. It was very good, but not very much time, only preparing the child to operate. And that was in this time. Now with the balloon and with the, you can do that also when the newborn is in the womb of his mother. In my time, that was impossible, and that was like a dream, nothing more. Thank you.
Thank you. So if the baby is born and there is an antenatal diagnosis, would you like the mother to be shifted to a center that is in utero transport to a center where there is a pediatric surgeon and the facilities are available? Professor
Yes.
Al, Professor Uchwa,
Yes, absolutely.
Yes, sure, absolutely.
Professor Salim.
Yes, this should be. In our few years back, we were working on this. We want to set up establish a setup in the Children's Hospital Lahore like this, where these complicated patients having the congenital anomalies prenatally diagnosed should be shifted to the center. But still, it is a dream. We worked on it, but we were unable to make such a center in Pakistan. Although one thing is a issue when there are children hospitals, they are usually isolated children hospitals in our part of the world. They are not attached with the other setup where the gynae or obstetric facilities are available. In these children, one concept was presented in our part of the world, mother and child hospital. That is actually a dream where the delivery is done in the same setting where surgical facilities are available. Now it is on the way. This should be. Otherwise, a setup should be established where at least complicated patients should be shifted with the prenatally diagnosed such sort of conditions, and afterwards they should be shifted to neonatal setup where they are resuscitated and afterwards seen by pediatric surgeons and operated in time.
Thank you
This
so much.
should be.
Another congenital condition in which we will advise in utero transfer of the baby is when the intestines are lying outside the abdomen through a small opening, a condition known as gastroschisis. Professor Alp, would you please describe what is gastroschisis?
Yeah, as you have mentioned, it's a interesting condition in a sense because the babies are born with a hole, with a defect in the anterior abdominal wall, just next to the belly button area, the cord, the umbilical cord. And through that hole, you see the intestines protruding through. And in the fetal life, they're obviously inside that water, amniotic fluid, and then the intestines are outside. So with delivery, this may be diagnosed, or as we mentioned, if there's an opportunity to do ultrasound examination beforehand, it can also be picked up prior to the delivery itself. So that's what is gastroschisis, and there are a few conditions that are very similar. There is another condition where the intestines also appears to be outside, but they're covered with a membrane. And gastroschisis is the one where there is no membrane. So what we're discussing now is, of course, these are the index pediatric surgical conditions that affects the neonates, and there are a number of them, and where our specialty deals, and this is one of them. And
Another condition.
Yeah. And if it's picked up earlier, again, it's wonderful if a pediatric surgeon is informed. If it's picked up earlier, I mean when the baby, before the baby is born, and an ultrasound is done, a so-called antenatal ultrasound, and it would be best for them to be seen by a pediatric surgeon so that the whole condition is explained to the parents. It's something that we also call antenatal counseling, and what to expect, because it's such a big shock for the parents to hear initially. But it's a condition that's treatable, and the patients, if it is managed properly, they have a wonderful life afterwards with good prognosis, as we would say. And being seen by a pediatric surgeon is one of the first steps that should take place before the delivery. Yeah.
So the take-home message from here is that antenatal scans should be done. While the prognosis is very good in developed part of the world, the developing world is still struggling with a lot of mortality because these cases are undiagnosed. Very few are diagnosed during the antenatal period, roughly around only 10%. And those that are diagnosed during the antenatal period do make it, with 80 to 90% survival, whereas those that are not diagnosed and do not reach the hospital well in time, because when the intestine is outside, it gets bloated up, it sticks together, and then it becomes very difficult to put inside, and a bag has to be created, and that bag can lead to infection and sepsis. So then the life becomes difficult. With that, we'll move to another condition known as posterior urethral valve. So Professor Ochwa, would you like to describe this condition, which also can be picked up during the antenatal period and can also have some intervention done in fetal life? How are they picked up?
The problem with the gastro cases is how long has been outside the abdomen before the delivery. Because sometimes the problem is not the operation. The operation is very easy. The diagnosis is very easy. And the problem is which possibility has some countries to send this immediately to a hospital. But I think the most important thing for us and for the prognosis is how long has been the intestine outside the abdomen in the womb in the uterus. Because if it has been a long time, you see that the whole wall, intestine wall, is damaged, is augmented, and then after the operation, you can have a very long paralytic ileus. And that is a problem, a big problem, not only this, but also with the adherence that sometimes you have it. That is my experience about it. Once operated, if the gastrocrisis has been very near the delivery, it's not a problem. And how Alp has said, the prognosis is very easy, the diagnosis is very easy, and the post-operatory is very good for the children. Thank you very much.
Thank you. So what about posterior urethral valves?
Excuse me?
Posterior urethral valve condition.
Oh, I think it's okay.
Professor Salim?
Posterior urethral valve is a condition in which there is a distal obstruction to the urinary outflow after the bladder. For the layman purpose, when there is a obstruction, it creates a backflow pressure effect. Bladder will be distended, and along with bladder, there will be hydroureteronephrosis, and there will be it will affect all of the kidney, ureter, bladder, all of the systems, and ultimately leads to the kidney failure.
We discussed we discussed a little bit about it yesterday also. So today we want to move to the antenatal part of it. So would you recommend?
I am going toward the antenatal part. No, it is something is good that majority of the gynecologists, they do ultrasonography themselves, and along with that, in the radiological setup, most of the ultrasonologists, they do the ultrasonography, and nowadays technicians are trained in the radiological setup. They are all able to do the ultrasound, and they are also taught about the prenatal congenital conditions, about these things. Usually in the cities and small cities, these facilities are available in our part of the world also, although it is a very good way available in the developed part of the countries. If they are diagnosed prenatally, then this patient should be taken into account, and these are the candidates who should be shifted towards the centers where early pediatric surgical or pediatric urological facilities are available. After birth, if they are diagnosed prenatally, if there is a severe disease, intrauterine intervention can be planned in these cases by putting some sort of evacuation from the bladder for the layman purpose. But usually these are not available in our part of the world. Fetal intervention is not available in our part of the world. So these patients should be early shifted towards the center where the pediatric surgical facilities are available, or pediatric urological facilities, nor they are also on the way, they are available. Immediately after birth, these patients should be in NG number 4 or 6 should be passed per urethra to decompress the bladder. And after this patient should be likewise, we have already discussed, they should be managed for hypovolemia, hypothermia, hypoglycemia, hyponatremia, everything. They should be corrected up and they should be maintained in the nursery. They should provide the free drainage. It is easy to pass NG in case of posterior valves, as its direction is upward, so NG can easily negotiate and they can be decompressed. Afterwards, taking into account their function, renal function should be assessed. Ultrasonography post-natally should be done. It should be picked up how much hydronephrosis is there, what is the condition of the bladder, and and blood investigation like blood complete, urea, creatinine, serum electrolytes, they should be done, and patient condition should be assessed, and a free drainage should be allowed. It is, I will say that this is also not a more urgent surgical emergency, but first the patient should be resuscitated, because if the patient is delayed, referred after the birth, they can suffer from the acidosis. They are dehydrated, they are having the acidotic respiratory acidosis, and they have a lot of problems. They should be first resuscitated, and then but the basic thing is to pass NG per urethra to decompress the bladders. Then they should be subjected for surgical interventions.
Thank you so much. So we've discussed quite a lot of congenital anomalies. Pediatric surgeons also deal with other conditions, surgical conditions, which the baby may get throughout his life up to the age of 18 or even 21 years in some countries. So Professor Alp, would you like to describe what are the lung infections like pus in the chest? How do they present, and what should be the treatment for that?
Yeah, I think the infection, when we hear about the infection, the main thing that comes to one's mind is the temperature raise. So that's number one. And when children have raised temperature, there are certain sort of areas in the body that we need to check if this infection is coming from those areas or not. And pediatricians are very good with that, and they would say, check the ears, check the urine, and then of course the lungs is the chest infections is another big component of diseases that can cause raised temperatures. So that's how the patient will present, with potentially cough, being not able to breathe well, or breathing very fast, and a high temperature, and that's how the patient would present. Investigations at the end in a medical setting will then determine that the patient might have a pus collection outside the lungs, in the pleural cavity, what we would call it, outside the lung and under the chest wall, and then there are ways to manage this, and again, they're not difficult to manage, and they're well managed in a setup where the children are treated surgically, but obviously the setup requires all the radiology and the expertise for these. So I think from the public point of view, any infection is important, and there are many infections that are very simple, and as children grow, they come and go, and there's often small viral infections that they would cause very similar symptoms to some of the diseases that are more important in a sense. So if it is something that's out of the ordinary, outside that simple viral sore throat type of thing, perhaps the best advice one can give is to seek medical attention, and which may lead to something that we've just discussed, a significant issue with an infection, with a pus collection in the chest. But again, hopefully the health systems, and one of the things that WOFAPS is trying to achieve is to make sure that there is health systems improving in every part of the world, and with collaboration between colleagues, and hopefully with these improved health systems in place, these conditions are picked up early and referred for treatment. Thank you.
So if a child is at home and having upper respiratory tract infection, high-grade fever, how many days should he remain at home, or after how many days of illness should it be a concern to show a doctor and then get a chest X-ray? Because as pediatric surgeons, we are referred these patients from the pediatricians who does an X-ray chest. So for the public, what would be the message after how many days of infection or high-grade fever should they visit the doctor for more investigations?
So we had a lot of conversations with mothers and our nursing colleagues and so on.
Mm-hmm.
So one of the things that we've been advised, and I feel that is one of the best advices that I have had myself, is that if the mother is concerned about the child,
Mm-hmm.
then there is a reason for the child to be seen by a medical practitioner. By a nursing team member or by a pediatrician or by a general practitioner. But if the mom says my child is not all right and I'm concerned about it, that's good enough reason for a medical person to see the child. Usually after a day or two, things need to settle down. But if it is not settling down, it's 48 hours, you still have a high temperature, and there's still very rapid breathing, then that's sort of a time period that one should say, you must go to the medical facility now. Often, simple viral infections, if they're causing the temperature, they would be settling down within that first 48 hours.
Thank you. So with infection in the chest, there may be another condition in which there is pus collection in the liver. And this is known as liver abscess, which we see quite a lot in developing countries. The cause may be something like not having a good hygiene or not doing proper hand washing and leading to amoebiasis or even pyogenic liver abscess. So Professor Salim, how common is this liver abscess in your country?
It is not very much common, although we have seen many cases in our hospital. Nowadays, one thing is that the pediatric gastroenterologist, they are also involved in management of liver abscesses. The patients, as you have highlighted, who are not proper hygiene is not maintained, their nutrition is not up to mark, it is infected, or there is some sort of a GIT infection, then it travels to the liver and it is caught up in the liver and it leads to the pyogenic liver abscess formation. These sort of the patient, if there is a fever to the patient is uncomfortable, have a pain on the right side, especially in the right upper abdomen and right hypochondrium or upper abdomen, or and has a fever, these patients should be investigated. These patients should, nowadays ultrasound is very common. Every person asks, sir, may I need to do the ultrasound? So these are the patients where ultrasound should be done early. And if there is a liver abscess, it should be treated properly by the pediatric surgeon or pediatric gastroenterologist. And in the early part of the disease, they can be easily managed with antibiotics, proper antibiotics, and if needed, by ultrasound guided aspiration. Nowadays, surgery was very common a few years back, but nowadays surgery is not an option. Repeated ultrasound aspiration leads to resolution of the symptom. And if needed, if complicated, then surgical option should be thought of.
So the take-home message here is do not delay early diagnosis and treatment, because we have seen cases in which this liver abscess may even burst open and even lead to empyema formation, the condition that Professor Alp has said. Professor Ochoa, we would like to ask you about worm infestation. Do you still have that in South America and North America?
In North America, you have very few infections, but in South America, it's very often. It's very often because the nurses, they are few that they are high classified, and they what you say, washing the hands, having that is in South America is much frequent than in North America, And in Europe, it's also very infrequent. In Europe, it's very infrequent. That is, in Europe, liver abscesses is almost unknown.
Mhm. So that is very good to know. So in our country, deworming program is being run by the government where we give these deworming tablets, that is albendazole, to school children, which they have in front of us, and we monitor them for any symptoms, which if they develop any side effects. Professor Alp, how is the condition in South Africa? Do you get worm infestations like Ascariasis, longworms, or pinworms?
Yeah, I think the sort of short answer is yes, we do get it, but it's certainly decreasing in numbers. 20, 30 years ago, we had more cases coming through, and it is much better now. And as you said, it's I would call this the public health side of pediatric surgery, because we, as pediatric surgeons, have been dealing with really very, very significant conditions that what one considers a simple worm might have resulted in. As you said, from liver issues to intestinal issues and many other conditions that become so complex. And if you look at it, at the basis of it, they have either an obstruction from the worms or it's a twisting of the bowel that we have seen many of them due to the worms, the gallbladder and the bile duct issues. The worms can travel to many interesting places and cause trouble, and then the liver abscesses and so on as well. So overall, they are decreasing, and that deworming programs are working very well. But again, we are still seeing them occasionally.
Another problem seen in our part of the world is hydrated cysts, which can happen with pet dogs and stray dogs. Do you have that common, and do you think we need to have some medications to prevent that as well?
Yes, hydatid cyst is also common. So that's a condition where a little parasite causes, and it has a life that takes the parasite between the human, but also the sheep and the dogs and so on. And that's something that results in a disease in, again, many parts of the body, sometimes in the lungs, sometimes in the liver, sometimes in lesser degree, but in organs like pancreas, and even the brain, and so on. So we are still seeing that, and in South Africa, there's one region where these patients mostly come from, and that's where the farming community is, and that's where most of our patients come from. So again, the techniques have developed to treat these patients. The outcomes are very good, and as the development of management happens, then the invasiveness of surgery also decreases. So in the past, where maybe a major operation would be needed, but today we're able to treat these patients with fairly simple, sometimes just with an aspiration and injection of medication into it. So that's also a big achievement, big development that we had in our field.
That's wonderful. So with infective causes, we now move on to appendicitis. Professor Salim, can you describe about appendicitis, which common man knows about? When should it be a concern? How should the parents think that maybe my child has appendicitis?
Usually the general community is well aware of appendicitis, word appendicitis, as few words are very commonly used, commonly known. Appendicitis, pneumonia, these are the common words with they themselves suspect these things. Whenever there is a pain in the abdomen, starting in the periumbilical or epigastrium, then shifting towards the right iliac fossa, it should be suspected that this may be a case of appendicitis. Usually it takes few hours to settle in the right iliac fossa, for the pain to settle in right iliac fossa. These patients should be suspected and referred to a setting where they can be properly diagnosed and treated early. At least these patients should be examined by the pediatrician, general practitioner, and then referred to pediatric surgeon and evaluated properly. In these cases, a complete history, as I have described, starting pain from epigastrium and umbilical region, settling towards the right iliac fossa, this should be taken. and a typical, a proper physical examination should be done. That is should be evaluated for tenderness, and especially more marked on the right iliac fossa and rebound tenderness. For the layman, if it is a abdomen is pressed on the right side, there is a pain, it is a tenderness, and when we leave it, and then a more pain, then it is a rebound tenderness. And if these are positive, along with the history, it is a near 80% case of appendicitis, although there may be some other causes which can make appendicitis. Then a blood complete should be done and seen whether WBC count is raised or not, and what about the neutrophils and lymphocytes, neutrophil are raised or not. And nowadays, it can also be, your diagnosis can be augmented with the help of ultrasound. And now ultrasonologists are well trained. They can help us by seeing the appendix, whether its lumen is increased or not. There is a inflammation on this side. There is a ileus in the right iliac fossa, or there is a few lymph node enlarged, or there is some, if it is advanced, there may be a mass formation. They can help you a lot in this case. And these cases should be early diagnosed, and early surgical intervention should be done in these cases.
So there is a sea change in appendicitis, and there is a management change also. In our part of the world, we still prescribe antibiotics, and some of them get treated with only antibiotics, and then we do interval appendicectomy. That also, if needed. Many children get away with one episode of appendicitis and never require appendicectomy. On the other hand, in UK, the first indication, if you think about appendicitis, you're not supposed to prescribe any antibiotic. You're supposed to confirm your diagnosis and take the child to theater. How is the condition in South Africa and then South America from Professor Ochua?
So the mainstay of treatment in appendicitis for us is still surgical. So that's number one. But having said that, it's again one of those developments that we're having in the field of pediatric surgery. The use of antibiotics and not the use of surgery under controlled conditions is also taking place. And it's a matter of selecting the right patient for the right treatment. And I think so we don't have one treatment option for all anymore. And it's certainly increasing in numbers, the treatment of appendicitis without surgery. But it needs to be done by colleagues, by surgeons, pediatric surgeons, or surgeons used to treat children with surgical diseases, and in a controlled environment.
Thank you. Professor Ocho, how is the condition in North America and South America? I'm asking you for both continents.
I can, about North America, the appendicitis, they do appendicectomy the most. Why? The same thing in Europe. In Europe, now in the Northern Europe, the northern countries like Finland, like Sweden, like Norway, and like Denmark, they are treating now more and more with antibiotics. But the insurance companies, that is a problem now financial. The insurance companies are paying the pediatric surgeons much more money if they operate it as they do antibiotics. Why? By appendicectomy, in 3 days, the child is at home. By antibiotics, you need 5, 6, 7 days. And that costs a lot of money from daily at the hospital. Therefore, the insurance companies are saying the doctors, the pediatric surgeon, we pay you more if you do an appendicectomy than you do antibiotics. And that is now a great war. Also, the pediatric surgeons, sometimes they convince the mother, what do you want? In 2 days, you have the child at home with a small appendicitis, operation, that is surgery, that is nothing, or 6 days at the hospital. There are mothers that they don't want surgery. And there are mothers that say, oh, better in 3 days, and I have the appendicitis away. In South America, almost everything is with appendicectomy. And in North America also, the stay at the hospital is very, very, very high. And an appendicectomy financially is better than by antibiotics. This war that is only financially, we will see what will be in 10 years. And also, as Alp has said, with the appendicectomy, you take the appendix out, you don't have any problem. But if you choose the antibiotic, you have to choose the right treatment at this moment. And if you don't choose very well, you can, I don't know how long can you stay giving him antibiotics at the hospital and with good results. That is, at the moment, it's a very big question.
So in our part of the world, if the child has appendicitis, they may be seen by a pediatrician also, or a pediatric surgeon, and we can prescribe them oral antibiotics also, which they can take at home, and the cost will be just less than $10 or maybe $5, maybe less than that also. So they can be treated with that. If the condition gets severe, we tell them if there is a problem, you have to come back to hospital, and the red flag signs are told to them, high-grade fever, or if there is nausea and vomiting, because once the child has vomiting, then he cannot be made to stay at home. But good antibiotics are available, and that has been the general practice now to prescribe oral antibiotics for appendicitis, unless it is really severe and the child comes running to the hospital in emergency situation. How is the condition in Pakistan, Professor Salim?
In Pakistan, usually, as Alp and Bas Ochwa has highlighted, the first treatment for the appendicitis is surgical, if it is diagnosed or suspected. But I will use the one of the term that is supervised neglect. It means this was done in the, this is usually used, this term is used in Perthes disease. Supervised neglect mean if you start with antibiotic, you should monitor the patients. Patient should be in your reach. Either it should be in the hospital, or if he is home or residence is nearby, he should visit you again in the morning, next morning. He should be in your supervision. Reevaluate on the next day, and if his symptoms are improving, you can wait and continue with antibiotic. And if his symptoms are not improving, then admit him and proceed for the appendicectomy. Sometimes I opt this. If so many times the patient's attendant do not accept the operative treatment, then we start with the antibiotic and monitor the patient and ask them to visit on the next day for evaluation. Although it is used many times in Pakistan, but it is not routinely practiced. Routine practice is that whichever patient is diagnosed at appendicitis, it should be operated until and unless he is on the improving side.
For the severe cases with the advent of laparoscopy, previously the Ochsner-Sharon regime used to be used quite often, but with laparoscopy, we have started going in lumps and taking out the appendix when it is inflamed. Has the scenario changed, Professor Alp, in South Africa?
Suppose yes, for sure. Use of laparoscopy has been brought in big time, and we've even done studies about this and published them. And from about 2010 or so, laparoscopy has become the main sort of modality. When we say laparoscopy, again, for the public, it's the keyhole surgery. So we do the operation through 5-millimeter holes in the abdominal wall, and usually about 3 little holes, or sometimes 4 is needed. And you can do the entire operation by looking at the camera and using special instruments and special equipment. And the benefits of laparoscopy is that they go back to full feeds after the operation in a shorter period of time, and the patients are discharged home in shorter period of time. And majority of the appendicectomies, majority of the operations for appendicitis now in our centers are done, at least in our center that I've worked, is done using laparoscopy with very good results.
Thank you so much for that. So with laparoscopy, that is keyhole surgery, a scope is put inside the abdomen, and even a search for any small particle of pus can be made, and a wash can be done. So better surgery can be done with laparoscopy under magnified vision. So we are able to see the abdomen on a screen in a magnified view. We would now like to talk about torsion testes, and that will be the last topic for today. Professor Ochua, would you like to talk about it?
What, excuse me?
Torsion testicle, torsion testes.
About torsion testicle, that is such pain that the mother brings up immediately the children to the hospital. Then they are diagnosed there and operated. And that is, I've said the most important thing is the mother. The child had such pain that they bring so immediately the child to the hospital. The operation, the diagnosis is there, and the operation is immediately done. Then how long has been? He can survive, or then you have to extirpate and put it, and later to put another one. But the torsion, the testicle torsion, in spite that you operate on time, that also 80% becomes infertility, and that has been by function seeing the spermatozoids are completely worthless, no good.
While giving public lectures, torsion testes is one thing which I realize the public does not know about at all. Even the media, even the grown-ups, if the mother does not know, the father does not know, how will they diagnose that such a serious condition can occur in the child? So I have been trying to tell school children that if you have pain anywhere in the body, do not keep sitting in the class. Tell your class teacher, and you may have a condition in which you may need to be rushed to the hospital. So till date, even today, we had a news media program, and none of them knew about testicular torsion, and they didn't want to talk about it. They felt it's stigma to talk about such a condition. How is the condition in Pakistan? Are the people aware about it?
Very few. I have operated few cases in the last few months. They came to me after 4 or 5 days when the testes are already gone. Pakistani people are the same like in India. They are not aware of the conditions, and they usually ignore the condition. Our GPs and they also give the painkillers and say ask them to come on the next day. These are the early part of the disease entity is very much important, as testes its vascularity can compromise with the passage of time. Within 24 hours, early intervention can give better results. And it also depends upon the number of turns, 360 degrees, 720 degrees, how much turns. If there are more number of turns, then the testes will be lost in just few hours.
So within 6 hours.
Very, very. It is a very, very painful, as Bas Achwa said. We should move for the awareness of our community that if there is a pain in the bowels or lower part of the abdomen, and it is so severe and it is referred into the from lower part to the abdomen, then it may be a case of torsion of testes. If pain starts with the trauma or with the playing or in the last part of the night when there is a retention of urine, if there is such sort of history, these patients should be evaluated by the pediatric surgeons. They should consult it. And early ultrasonography or color Doppler should be performed. And if there is a suspicion of torsion of testes, you are not able to rule it out, then I think exploration is better. We should not ignore in this.
So when taking such a child to the hospital, the parents should be mentally prepared that the child may need an urgent surgery during the first visit to the hospital. Professor Alp, would you like to add some comments on torsion testes? And then I would request you to please wind up the session today.
Thanks very much. I mean, I fully agree with my colleagues as well. Of course, the painful swollen scrotum as far as we're concerned, it's a surgical emergency, and a pediatric surgeon needs to see. And it is a difficult condition for, I can imagine, a child to come up with and explain or tell the parents, or may feel shy about that. And I think doing work in schools and public to let children know that anything that that they're unhappy with in terms of pain, they need to seek medical advice. And the outcome is, it may not be torsion as well, and it may be something very simple, but may still require surgery. So I think from that perspective, it is very important. So as a closure words, thanks so much again, firstly to Professor Sharma for setting this up, and to my colleagues, Professor Boix Ochoa and Professor Salim. It's wonderful to again meet up from many different parts of the world and be able to discuss these conditions in a format that we hope the public will engage with and will interact with, and we love to hear more from them. We are not used to creating YouTube videos, but one thing I hear when I watch YouTube videos is they say, remember to subscribe, remember to like and make comments. We'd love to see the comments coming through, and through those comments, we will be able to, of course, structure the format of these talks, and would love to have colleagues joining us from other parts of the world too to attend to these meetings. Shilpa, back to you.
So
Thank
Professor
you very much.
Alp has made a very nice movie on appendicitis, and I would request him if we can put that link in below in the YouTube link for this.
Yes, absolutely. That's actually a storyline where we've got a child who had appendicectomy acting in a movie as a patient coming in with abdominal pain, and it's hour and a half movie with 4 parts. It's all staged. It's based on a scenario. But it is a medical education video, but it also very good for parents to see too. You're more than welcome to share it, Shilpa.
Thank you so much. So with that, I thank Professor Alp, the president of the WOFAPS, Professor Boix Ochoa, the well-known figure who has started the WOFAPS and he has been around for 50 years now. Thank you so much for the support that you give to the association and bring it up. Lots of thanks to Professor Salim for representing Pakistan and Australasia in general. You have been a big support and telling us about things happening on that part of the world. Thank you all, dear viewers. Thank you, everybody. Thank you. Thank you.
I want to thank and to congratulate Alp and Shilpa what they are doing now with WOFAPS. You have begun bringing WOFAPS forwards. It is a new cycle. I have dedicated a part of my life to WOFAPS, but I am so happy to see that WOFAPS is so strong, so strength, and that is thanks to you both with the idea that you have brought with the webinars, with the pediatric surgery day, with everything that you have done and you are doing is also marvelous. And I can say from my point of view, that has been a part of my life. Thank you very much. Thank you very much. You are doing an excellent work, and you have begun a completely new cycle of WOFAPS. Thank you. Thank you.
They have the credit of introducing World Pediatric Surgery Day. It is a big achievement. This time in Pakistan, it is celebrated on wider scale in Lahore, Rawalpindi, and Karachi. Walks were done, and there was a session on the pediatric surgery, and there were writing in the newspaper and on the TV, on the TVs. I gave them the credit that they have make it practical, make it possible to celebrate this day. Thank you all.
Thank you. Thank you very much.
Thank you. Thank you. With that, we end this session. Thank you, everybody. Thank you.